Okay guys, so in this particular module, I'm going to be demonstrating a number of instrumentation that you're going to use and a number of products that we're going to use frequently, whether you come to the bone grafting extraction course or even the implant course. Because in the implant course, we do have a lot of extractions and immediate implants. So you're going to be using all these things, and I want to show you some key principles that are pretty easy to follow. Okay, the first thing I want to share with you is when to use Memlock. Now I have to point out to you, there's a number of companies, no matter what I'm showing you tonight, that have similar products. This product I'm showing you, Memlock, is from BioHorizons, and they're just a company that I've been using for years and that I'm very comfortable with. Memlock, which you should know, it's not analogous to like Collotape. This material is described in the literature as cross-linked. What that means to you is that it lasts about 36 weeks. And in many cases, that's how many weeks you need. It's only 6 weeks, or it's not even 6 weeks. And it'll last long enough for the bone regeneration underneath of it to take place. If you put in something that's not cross-linked, the maturation of the bone underneath won't be complete. So how do you do this, and when do we do this? Well, a lot of times, no matter what we do, we just got done talking about atraumatic extractions, remember? And we talked about preserving the buccal bone. Well, what if the buccal bone's already gone because of an infection? Or maybe you did break it no matter what you tried to do, like on a cuspid. It's going to happen. So this is a very common membrane. And to be quite full disclosure, for years, it's all I used. I didn't use the other membranes that are non-resorbable. This is resorbable, which obviously is a very good feature for us in a busy clinical environment, right? It's a little easier to place and use than non-resorbable, which we're going to talk about, coming up. So what do you do? Well, let's pretend it's not here, but let's pretend there's a buccal defect right there. And so the membrane is cuttable. So you just take a pair of surgical scissors and cut it to where you want it. It doesn't matter what side you put down, which will be different when I introduce the next non-resorbable membrane to you. So it doesn't matter whether you put this against the buccal or the other side. So I have to point out to you that when I'm doing complicated surgical procedures, I'm always using 2 assistants and very often 3, because the third one sometimes will be responsible for just holding the lips out of the way. Okay, so you get what I do is this. I have my grafting material ready to go and mixed, and you're going to find out at my institute that we almost always use a mixture of 70% minerals, which is cortical cancellous bone, 50% of each. It is mineralized, and we mix it with 30%, and that's really, we do that by eye, our eyeball test. We mix it with 30% of Mineros X, which is a bovine bone. Now, why do I do that? Because you got to remember that this material is all going to be replaced by the human process of angiogenesis. So when we want it to last a little longer because it's a bigger defect, so you wouldn't put this in a socket, by the way. You would just put straight Mineros in a socket. But when we're growing buccal bone back, we need more time. So that's why we use a combination of 70/30. 70 minerals, mineralized bone, with 30% minerals X, a xenograft. Okay? So that's the bone we use, and it's very easy to learn how to use this, and you're going to do numerous cases when you come to the course. So let's pretend that there's a defect there, and what I do first is I cut out the membrane to the shape and size that I want first. Once I get it in place, then what you're going to do is you're going to use a tack system. It comes with an instrument that you just go straight down, and it picks up the tack. So the tack now is in the instrument. So you bring that around. It's important not to go in at an angle. You don't want to do that. You want to come in at a perpendicular approach to the bone. And you line it up to exactly where you want it. Remember, I have a dental assistant helping me. And you simply tap it into place. Now, important, when you disengage, you come off at a slight angle. And voila, there's your tack in place. And I put usually, the purpose of the tack is to stabilize the membrane. If the membrane moves around, you're not going to form bone. So one on the mesial, one on the distal. Sometimes if it's a large defect, I'll put 4 tacks in. Remember, I'm sharing with you years of research and years of recommendations by people like Mike Picos. And I have to tell you that the half-life of information changes about every 2.5 years. Somebody will come up with something better. But I've been using this approach for years. There's probably many clinicians that don't use tacks. They just lay this down. I like it to be stabilized. I've never had a problem with it. Sometimes I don't even go back in and get the tacks back out. I leave them there. That's, it's been my approach, and it has never caused me a problem in years and years of doing this type of surgery. Okay, so that's how you're going to use this. You're going to cut it to size, and we're going to be right there with you showing you. So I'm not expecting you to, I just want this module to give you some familiarity with the products that you're going to have in front of you when you come into the surgeries that day. And there's no doubt that every one of you are going to be using this approach at one point. So this is a resorbable membrane. It'll be gone in 36 weeks is how long it lasts. If I didn't say that, that's what I meant. So that's what we want. And again, you don't have to go in and retrieve the membrane. It may be your philosophy to want to go back in and get the tacks. I don't know. Okay, that's that approach. Real quickly, and I would assume that all of you have had some familiarity with a collagen plug. So when we're in a socket like this, when we haven't blown out the buccal wall, and we've placed an allograft that's bone from another human. When we placed an allograft, you don't need minerals X. You don't need bovine bone in a socket if you have 5 walls. Then I like to cap off the top of it, because imagine that I just filled the socket with bone. So we just take a small piece. I mean, it doesn't get any easier than this. Adapt it to the socket we're trying to fill. And remember, there's bone underneath it. And that's that. Again, I would assume many of you have had that experience already. But it doesn't get much easier. This, of course, the larger the defect, the more complicated and the more work we have to do. It's just the way it is. One more thing before this module ends would be, a lot of you are going to be doing, using a 15C and making more flaps than maybe you've made in the last 10 years when you come to the course. So just, again, I'm trying to share with you some critical secrets to making your life easy. When you're using and making a flap, 9 times out of 10, I'm doing this for the camera's sake right now. So you see me going from the mesial to the distal, but it's the opposite. We almost always go from the distal to the mesial. But that's not what I'm trying to tell you. Make sure that the blade is well within keratinized tissue. If you have just a thin strip, which in some cases you're going to have, cheat so that most of the keratinized tissue is on the buccal. Okay? Maybe you have just a millimeter on the lingual. And then when you sink your blade in, this is key, you have to be feeling bone before you start to move the blade along the bone. If you don't feel bone on the tip of this blade, then stop. You insert, you feel bone. It's called scoring the bone. Kind of means scratching it. Because if you don't do that, when you go to elevate your flap, and you're going to be using this is called a Molt 2-4 elevator. You're going to be using these every patient. They have 2 spoon size on each side. One's larger than the other. When you go to engage the flap that you just incised, you go down again to the bone. It has to be on bone. If you don't, you're going to struggle. Otherwise, the flap becomes, if you do it correctly, flapping just becomes a very, very easy part of your surgery. So it's not uncommon for me to go back in along the length of the incision and make sure that I can feel bone. You know, and when you go into an area that's been surgerized prior, you have scar tissue there. This is not as easy. You might be thinking, well, that sounds really easy. It's not always easy. And you want a clean incision. It's best to go in once, know where you're going, and bring your 15C while it is on bone. Okay? And we'll talk more about vertical releasing incisions, which you're definitely going to do at the course. You're not going to be able to get by with just crestal incisions, which is why you're coming here. So we'll go over sulcular incisions. We'll go over crustal incisions, and where do you need vertical releasing incisions. And I think most of you are going to experience the fact that you're going to be much more aggressive when you leave here than when you got here. In other words, when I ask you to do a vertical releasing and I have these courses, what I notice is that they're under incised. They're not big enough. And you don't want to be stretching and tearing tissue. You see, the incision, the body doesn't know whether the incision is 10 millimeters or 25 millimeters. It still heals the same length of time. So why wouldn't you overextend the incision a little bit to make manipulation of the tissue easier, as opposed to, and it's just natural. If you don't have a lot of surgical experience, it's natural to make a little tiny incision and a little tiny flap. And then what you really end up doing in that case is more harm than good, because since you have a small flap, you're stretching it and you're bruising the patient more and traumatizing the tissue more. So you'll see me encourage you to make longer flaps, because a long flap or a short flap, if they take 21 days to heal, it doesn't take any longer because the flap was longer. Make sense? Okay. And that's all I want to talk about in this module.